recently joined with the American Journal of Managed Care to launch the Community on Payment Innovations. Joining me to discuss the issue of payment reform, as well as this new community, are ACC CEO Jack Lewin and the community's editor-in-chief and healthcare economist, Len Nichols. Gentlemen, thank you for being here.
Thanks, Lisa.
What are some of the biggest problems with the current payment system?
Well, for one thing, the fee-for-service payment system is something that we know a lot of people are frightful of any change of anything, but it's a very awkward system. It rewards volume rather than quality. You get paid more for doing more. You get paid more even if the care isn't needed or something happens and it requires a complication that requires more care. It's not a system that leads us toward a more effective, efficient healthcare system. And it's incredibly complicated and administratively complex in the sense that a physician's office has to hire a bevy of people just to deal with the coding complexities in it. So it's administratively complex. It rewards volume instead of better performance, and it really just needs to be changed.
So speaking of changing, Len, what are some of the newer models that are being considered?
Well, one idea is to take these 8,000 CPT codes, which we now pay physicians with, and lump them into bigger bundles. Because the whole idea is to give clinicians incentives to minimize resource use while delivering optimal quality care. They know how. It's just like Jack just said, they're now incentivized to do lots of stuff. And frankly, our malpractice system is pretty bad, and it encourages people to do things that are not necessary, for which they get paid. So the combination of incentives are wrong. What we need to do is make the bundles bigger, give the clinician the incentive to save money to deliver patient care, and that's how you get win-win out of this.
Jack, ACC is looking at some progressive payment models. Can you talk a little bit about what those are and how they work?
Well, we're looking at the array of what the opportunities and options are. I mean, in some programs and some practices, tweaking fee-for-service with some kind of incentives for better quality may be the way we start and move in the right direction. But in other practices, bundling, as Len just mentioned, will be appropriate. And if you look out there in the real world of cardiovascular practice today, in large integrated groups and larger practices, some of those folks are already working with global budgeting or capitation, where they're actually managing the whole budget, sometimes with partners with hospitals or with other physician organizations, to take care of a whole population of people in a more effective way. If Willie Sutton was going after the best system in the future, probably that kind of a global budget approach would be the most attractive if the insurance companies were playing fair, it was all transparent, and everybody could see how the dollars were moving around.
Big if.
Well, in the Door to Balloon campaign, for us with improving speeding up the treatment for heart attack and for ST elevation myocardial infarction, heart attack, we've saved billions and billions of dollars for the nation by improving that treatment system of care. And hospitals got nothing for it, doctors got nothing for it, all the money went to the payers. So we've got to develop a kind of transparency out there so that payment reform allows everybody to understand what's happening and be rewarded for their performance.
Len, talk a little about the new Community on Payment Innovations. What are key features of it?
Well, the basic idea, Lisa, is to bring ideas from around the country that are going on now to everyone's awareness. So essentially, we're like a reporting function, or it is like journalism. We want to find out what is going on in real time to report, so other clinicians can say, well, I've heard these conversations and people are starting to talk to me about similar things. I should think about what I know is going on elsewhere before I make a decision to inform the choices that clinicians are making. Jack made an excellent point. Fundamentally, this is about figuring out how to move us from where we are today to a better set of incentives. No one knows how to write down all the math to make it perfect. We know we need transparency. We know we need fairness in dealing. We need data. But I think it's fair to say a lot of what is good is already going on. We don't have to reinvent something completely out of whole cloth. We just got to take what the best of America is doing to the rest of America, and our community is about helping that transition occur.
Well, that is so right. Yeah.
What other things do you want to accomplish with this community?
Well, we would love to engage more cardiologists in what you might call the economics of the discussion. You know, I'm an economist, so I love this stuff. I deal with people in the payer and employer communities who are always thinking about this stuff, but we're not docs. Turns out that really matters. Turns out what you really want is for clinicians to be deeply engaged, just like ultimately you want patients to be deeply engaged in making these choices. And they will do a better job, I think, of helping us structure the incentives if they're engaged from day one, as opposed to, here's your new payment schedule, good luck.
So, Jack, what's the ideal payment system 5 years down the road?
You know, it's hard to say what that is. I think we'll figure that out through our experience. But it may very well be that more doctors are happier with in some kind of larger organization with a salary and a set of incentives. Maybe 50% of their pay will be incentives based on improving quality, improving efficiency, and perhaps patient satisfaction and other physician satisfaction. That may be the easiest for docs to understand in the future, and might allow us to get back to seeing patients in an environment where actually payment is fair. But it might also be in one of these other models that has developed and works.
I would expect, as diverse as our country is, there's going to be more than one model in the long run, and that's okay. I would say the best payment system is one that enables us to deliver health care to all Americans that's high quality, that we can afford, both as people and as a society. And if it's different in Greenville, South Carolina than it is in Seattle, so be it.
And hopefully administratively simpler than
It's got to be. We can't
current
afford it.
quagmire.
It's got to
we're in.
be, yeah.
Well said. Gentlemen, thank you for being here with us.
Thank you, Lisa.
Appreciate it.
My pleasure.
That is it for this edition of the ACC Update for October. Join us next time and continue to watch all the news from your college on CardioSource.org. I'm Lisa Fletcher. Thanks for watching.